apie šios konferencijos pradžią prisiminiau profesoriaus Mažylio pranešimą, kurį jisai darė 1930 metais pirmojoje konferencijoje, kuri vadinosi Motinos ir vaiko sveikatos pagerinimui skirta konferencija. Tuo metu profesorius sakė, kad daug kas pasikeitė Lietuvoje, tačiau tuo metu gimdymų iš 70 tūkstančių gimdymų Lietuvoje kasmet mirdavo 1000 moterų. Ir ne pačios geriausios statistikos įvertinimai. Mes iš tiesų Lietuvoje šiuo metu mūsų rodikliai motinų mirtingumo, kūdikių mirtingumo yra europiniai, atitinka europinius standartus ir rodiklius, už kai kurias Europos ir sekmės yra geresni. Taigi nueitas labai didelis, labai svarbus ir reikšmingas kelias ir mes galim lygiuotis į pačias geriausios akušerinės praktikos šalis, tokias kaip Skandinavijos šalis, savo rodikliais ir tiek motinų, tiek vaikų, tiek naujagimių ir to negalima nuneigti. Tačiau turbūt didžiausioji svarba šitos konferencijos, kad mes turime kalbėti ne tik tai, kokie rezultatai, ne tik tai ką, kokią paslaugą, kokią priežiūrą mes siūlome, bet ir kaip tą darome, kokioje komandoje tą darome. Manau, tai yra nepaprastai svarbu, kad mes jau turime pereiti į kitą etapą ir iš tiesų komandoje savo turėti ne tik tai medikus profesionalus, bet ir tuos žmonės, kuriem mes teikiam tą pagalbą. Tai yra moteris, tai yra jų šeimos narius. Ir todėl manau, kad šitos konferencijos pats svarbiausias uždavinys tai yra padiskutuoti ramiu tonu, padiskutuoti šypsantis vienas kitam, stengiantis suprasti, kad nebūtinai visi galvoja taip, kaip aš šiandien galvoju. Taigi aš tikrai visus labai kviečiu geranoriškai diskusijai, mokėjimui išgirsti vieni kitiem ir tikiuosi, kad šita konferencija tikrai ne paskutinė. Mes turime ir kituose klausimuose pasiklausti savo pacienčių ir jų šeimos narių. Ir tikiuosi, kad mes vis dažniau savo profesinėse konferencijose turėsime ir savo pacienčių atstovus. Ir prašom tada paskelbti mūsų pranešėją.
Labą dieną. Ačiū gerbiamai profesoriai. Ačiū šios konferencijos organizatoriams. Tikrai mes jau vasario mėnesį diskutavom apie šios konferencijos svarbą. Ir šiandien labai džiugu, kad toks gausus būrys akušerių susirinko į šią salę. Ačiū gerbėmiems gydytojams, kurie rado laiko būti šalia mūsų, ne tik darbo vietoje, bet ir konferencijos metu. Ir tikrai tikiuosi, šiandien visoms bus smagu pamatyti Lietuvos akušerės tarptautinėme kontekste. Ir pirmajam pranešimui kviečiu viešnią Europos akušerių asociacijos prezidentę. Labai džiugu, kad Lietuvos akušerių sąjunga taip pat šios asociacijos narė. Karališkos akušerių kolegijos Akušerijos valdybos patarėja Mervi Jokinen.
I'm very pleased to see so many faces and opportunity more likely to discuss maternity in Lithuania, which I must say that I'm not an expert on and I'm only just learning, so it's a very important visit for me. Yesterday I had an opportunity to visit Kaunas clinic and I hope there's some of the colleagues from there because they were extremely hospitable, they were very friendly and I really liked the clinic and I thought I got a good insight on the quality of the care that is provided in Lithuania, at least within that hospital. So what I'm going to do on this presentation, I'm actually talking about in my role as president of the European Midwives Association, and I'm talking about some of the surveys that we have done about midwifery and maternity across Europe. And just for some of you who may not know about it, European Midwives Association is a non-governmental association. We have 31 members, member associations from 27 member states. And we have a very clear constitution of our vision. which is about promoting women's general and reproductive health in Europe. And if you look at the second bullet points, I'm not going to read through all of them, but you will find that EMA has very wide aim. We are focusing on the midwives education. We focus about standards of care within the general and reproductive health. We also work with the Commission as providing the midwives voice when we are looking at any kind of health or even workforce directives. So it's a very important role because we do find that the midwives have a really small voice and we are getting bigger and bigger. Our sisters, the nurses, in numbers are so many more than the midwives that we find that it's always troubling. I seem to be saying more, but the midwives, just to make sure that they actually understand that there's a differentiation in many countries between nurses and midwives. So this is the basis of everything as health professionals, doctors, pharmacists, nurses, midwives. We have our own articles in the directive that are quite regulatory in their role of saying what the different health professionals can do and how we should harmonize our education and standardize our care across Europe. And the surveys that I'm going to talk about are based on this directive. But I must admit, the directive in the last 2 years have been looked into, and it's been gone through an evaluation and modernization. So the new directive will be having its last vote actually next week within the Council, and there will be changes into some of the midwives' articles. Not enormously, and actually not so much into the activities of the midwife, but certainly there's an upgrade that all the midwives will have to can only enter the training after they have had 12 years of general education, which of course means that the midwifery has moved into a degree level course or training course. And within, I mentioned, because again linked to the survey, within the article, one of the articles, there's the person activities of midwives. And I've only given 3 examples here because the surveys that I'm going to talk about cover antenatal, intrapartum and postnatal care. And these are just examples of what midwives should be able to do in each country. And they become a little bit more linked when I show some of the findings. So it's about diagnosis of pregnancies and monitoring pregnancy, so caring for the woman all through the pregnancy, as much as looking after and monitoring the woman in labor and conducting births, and also that midwife has a role in the postnatal period. So straight into the surveys. What happened was that in 2009, we decided that actually it's a good idea because we knew that the directive was being looked into, and also that we recognized that EMA itself was becoming much stronger. We recognized that we need to have some understanding when we are at the table to actually talk about what midwives do in the different countries. So we did an antenatal, intrapartum and postnatal survey on those subsequent years. And we had about 78,000 representation of midwives from different associations and responses from about 25 countries. And that was the membership on those dates. We have now increased our membership. So within that survey, we covered about over 5.5 million births per annum, which would have been the number of births across those member states. So you can see that the spontaneous birth rate of actually normal birth varied quite a lot. It varied from 86% in some member states to 50% in the others. And accordingly, also the caesarean section rate was anything between 14 to over 50%. That's an enormous difference. And if you look at the human being, a woman herself, there shouldn't really be that much variation within European population. At over 50%, especially like in Cyprus in the current Veristat report, 65% of women have a caesarean section. It this cannot be medical indication, and I think because EMA works very closely with the European Board of Obstetricians and Gynecologists, these are also issues that we are addressing, and it was part of the survey that tried to explain to us how midwives' role varies because of the system, but because also what happens in those countries. So the surveys are not about criticism about any health professional. They're talking about what is in that country, what does the health system drive the outcome to be. And I think some of those countries we need to ask, is the health system driving, because of financial reward, etc., women to actually having a cesarean section? Now, I might be lost now because my slides are not up there. But anyway, my Lithuanian is not very good. My own slides. Basically, what we are looking at is that in the surveys, I mean, what we did find, that it's quite difficult to compare different statistics. And also that when you do a survey across Europe, I am so expert on it now, language is a real problem. Because even we all work within the English because that's the EU language. We actually had to make sure that the translation made sense in other countries. And often it doesn't, because you use different words for birth, delivery. It means different things to different people. So in reality, that was one of the difficulties. And the health system, of course, so you couldn't ask exactly the same question sometimes. So we tried to keep it very, very simple. And on that basis, the most accurate data basically was all the clinical questions we asked. If we asked about, did you do hemoglobin levels on the woman in pregnancy, everybody knew how to answer that. You know, there was no problem at all. We could compare yes, no, or whatever. And there were some concurring themes. Same themes occurred in all three surveys. And one of them was that there definitely is not opportunity for midwives in some countries to able to practice as it says in the directive. And this is what we wanted to find out. We wanted to find out if midwives were really doing what the directive said they should be doing. And also, many of them couldn't practice autonomously. They were more like an add-on to the doctors, working more like an obstetric nurse. And of course, the importance of this is that as a midwifery community, and especially European level, when we are looking at our education, we need to be very clearly aware that if the midwives themselves are not practicing as midwives, they cannot teach the students the science of midwifery or theory of philosophy of midwifery, but also they don't have the students will not have those experiences. And we look at something like a home birth or environment or anything like that. So the students are also missing out. So this is my first slide. And actually, I said that this would work, but I'm not quite sure now that if it would work because I need to show you. So in this area here, we asked if there is a requirement for number of antenatal visits that the women do. And in those countries, there's a definite requirement. So by law, women have to receive a certain minimum number of visits. And in these countries, so it's sort of half and half. And why I have chosen some of the slides is to try to share that this is about the health system. So I haven't done many of the clinical things, this is about the health. In these countries, if they have actually the minimal, we wanted to look where, if it was linked to maternity benefits. And in these countries, it was linked to the maternity benefits, and these were the minimum visits. So again, when we are talking about the health system and the cross-border healthcare, we already see there's quite a lot of variation between 10 and 3. And this is a very difficult slide. So what we looked here is how much are the doctors are privately attending to women in the antenatal and postnatal period. And why we needed to look at this was that because the midwives were saying, well, we can't do that because the health system, the health insurance insists that the women have to see the doctors, otherwise they don't get the money, and also they see some of the maternity benefits signed up. So if you look here, we have 6 categories. We have 0 to 2, 3 to 10%, 11 to 50, 51 to 75, 76 to 95, and then plus 95. And this is the antenatal time, and this is labor and delivery. And these are all the countries that we surveyed from this survey. And if you look at it, for example, in Denmark, the private, the doctors are not involved actually antenatally, but they are involved, they're only involved 0.2% antenatally, but they're actually involved 76 to 95% in labor. And in these countries here, actually the doctor is involved antenatal, so we would sort of consider from that information that actually those women in the countries, and you will see later, they would be seen by a doctor throughout their pregnancy. And I'm just trying to look if I can see Finland there, because I know the countries like Finland. I know the countries anyway where midwives are not really involved with the antenatal countries, so I try to sort of pick them out. But in this country here, which is Latvia, which I'm not sure if it's true, but it does say that the doctors are actually caring for women all through most of the time in pregnancy and labor. I'm not quite sure if I'm doing this very well on a long distance, but anyway. So in this chart here, what we are looking at is that if the countries said that the women have to be seen by a doctor, so that would mean that in countries like United Kingdom, which is where I practice, I know, the women don't need to see a doctor at all. So if the woman chooses to be with a midwife all through the pregnancy, there is no need for a visit. But in those countries where it says tape, I suppose here, they said yes, women do have to see a doctor through the pregnancy. So actually, again by the directive, midwives are not always able to provide antenatal care for the women. And this second column here would be the reason why the women see a doctor. So some of them, it is an ultrasound. So if it's only one visit and it's ultrasound, it's quite understandable. So it would be known that the midwife is actually providing medical care. And here is the rest of the visits. And in this one, just go back just to make sure. In this one, we asked the countries where midwives can see only a midwife, and self-explanatory. So where midwife would be the only one, and the women don't need to actually visit doctor. And there is quite a few countries where that doesn't happen. And this is then about choices on the place of birth. So actually, we asked that in your country, do women have a choice where you give birth? So that's sort of quite relevant on our meeting today. And you can see that quite a few countries didn't have a choice on a home birth. Even more countries didn't have any facility like a birth center, and in this case, birth center was defined as an environment where there's only low-risk women, and they would be having normal, healthy pregnancies and normal births. And then, of course, everybody had opportunity in the hospital. And because it's always about choice issues, also in your health system and what you can have. We also asked about these questions in labor. And as you can see, the highest level of answers where women had choice was paper leave. And there's no question about it. And then there's variation about if women are able to eat or drink in labor. This one is, I think, is very important because we asked the question that if the woman comes into the hospital in labor, because she thinks she's in labor, who is the health professional who normally checks that the woman is in really labor? And if you look at the directive, this is clearly a midwife's role also. But we still found that there were quite a few countries where midwife was the person doing it. Then there were countries where only doctor did it, but also there were countries where both health professionals did it. And that really, this is the one that we need to discuss, and we discussed with the EPCO. With the current economic situation and with the sort of loss of health professionals and cutting down of services, it is not really economically viable that two highly professional, educated people have to do the same examination to diagnose that the woman in labor. And it certainly would be outside our scope. So I think that's a good discussion point with us here. And then I just quickly move on, because I think this is much slower, because I'm not doing it as smoothly as I would like. But we looked at the postnatal period. And it's quite apparent that many countries, midwives don't provide any postnatal care outside in the community. But as you can see here, there's many countries like Netherlands and Estonia, well, Norway, Portugal, UK, Slovenia, that actually have the postnatal period which is 42 days. So we would expect that the midwife would be involved all through that time. And also in some countries, which as such is outside the scope of the directive, you know, the midwives are involved in a postnatal care for over 9 months or even 12 months. And in countries like Sweden, it varies on the station. So again, because we were looking at the system, we just looked at the health professionals who were involved in the postnatal care, and you can see the differences here. With the mother, it's either obstetrician or pediatrician with the baby. And many of these countries, when we looked at it, especially like Cyprus and Greece and everything, the midwives didn't really have a role on checking the baby or caring for the baby. The baby had to see a pediatrician specifically. And that was linked again to the health insurance. The money wouldn't be paid to the system for midwife seeing the baby. It would only be paid if the pediatrician saw it. So again, it was blocking the access of midwife actually just undertaking that activity that she's supposed to be trained for. And she needs to maintain her competence in all of these. So, in conclusion, I think, again, as I said, this is not about individual health professional and saying, you know, why is it that the doctors are stopping midwives doing this and why is it about that? It's actually looking at how the systems vary from country to country and how, if we do harmonize the training and the education of the midwives, what will happen to them after they have been highly educated if they're not able to undertake the role? And certainly, as I mentioned before, EU has now several directives, and also it has its own overall plan, which is called EU 2020 strategy. And within that, EU believes that the single market is an answer not only for health professionals' mobility, being able to work from country to country, but also in providing care. And the policies and directives on the healthcare, like you can see here, both the job recovery and especially the action plan for the EU health force, is looking at all the member state countries, and they're looking at the health workforce. And they're making very clear that they expect that each member state will assess their health workforce. They will see that there is going to be an equal number of, there's going to be a balance how many nurses, how many doctors, how many midwives, how many other health professionals that there are in the workforce. And we are really interested because there's a lot of work and money put into making these assessments on member state level. And don't think you can just get away with it, don't you think? But the member states can't actually just sit down and say, well, they can't touch our health system because that's often on a national level, like what we say. The EU is actually now making recommendations for each member state, and they expect you to fulfill that. And if you don't, you will be financially penalized. So there are much more drivers and strategies for the governments to having to take note from the EU as there was previously. And of course I mentioned that the EU directive of the professional qualification is going to affect all of us, and it also will be having a second phase which is about the competencies. So healthcare workforce itself. As I said, there's a plan for sustainable workforce, but it's very, very complex because I think, Rita mentioned to me this morning that as the first bachelor level degree midwives are coming on, so you can see it takes 3.5, 4 years to actually produce the next generation of midwives that are under that EU directive degree level. And if you think that your birth rate is this, and you've got this many doctors, and you've got this many pediatricians doing this, and then suddenly you change direction, and you start to think, well, the midwives, like in UK, midwives do the first main physical examination of newborn, that often pediatricians do. If you move into that, you have to train these midwives, you have to plan ahead. So your numbers of workforce you are talking today are actually those numbers that you expect them to be 3 or 4 years later. And we need definitely assessment about the education if you're going to expect it. And I think this is just another study that they're doing. And from this study, I'm going to just quickly show you 2 slides, because I think it's worth looking at this study as when you look at your own country. These 2 slides here, and I wish I now had actually the English done, but in this first one, you will see how many nurses per population of 1,000 people. So this is not about maternity, and I couldn't do midwives because there is no data in this level of midwives, there's just nurses. So you can see on these countries, Denmark and Iceland, you have several, much more numbers of nurses per 1,000 than you have on these countries. And then, when you look at here, this is nurse to doctor ratio, and again I'm not talking about midwives, but nurse to doctor ratio. And can you see how this has sort of turned itself here? Have you actually done this? Right. Yeah. What you have is you have much more nurses per doctors, which means actually that nurses, and if we look at the midwifery, nurses are doing much more in these countries than in these countries. You actually have a higher population of doctors available in these countries, and nurses are nearly equal, if not 2 to 1. So do you understand what I'm trying to say? I'm trying to say that actually there isn't this balance that I was talking about a workforce, and the country itself had to ask, well, who earns most money? And is it actually economically viable when the other health professional can undertake that role also? And this is a very quickly, and maybe interest you, because it does mention Lithuania here, and this is just to say that the numbers of midwives have stayed quite static, but there are some countries that are struggling at producing or introducing degree level midwives. So in conclusion, I just want to again say that EMA has an important role, but it only has a role in EU and voice in EU if we get the midwife in each country to engage with us. And your Midwives Association is a member of EMA, and we need to responses to surveys, we need they want us to take to the Commission, they want us to take to the EU Parliament, so that the numbers and the voices of yours is done. And obstetricians have the similar organisation, as I said, and that will happen to them too. And we also have a very high principle that we will continue campaigning for humane and equitable childbirth across Europe. There's divorce, Millennium Development Goal 4 and 5 that are appropriate to us. And we often look at the African countries and we look at all globally, but actually we should sort out also what's happening in Europe. We should see that we need to reduce perinatal and maternal mortality. And EMA has a role in that too. And as I said, the work within the directive, the next phases, the competencies, we will be continuing to work with that too. And we are very pleased that we were able to get the degree level education article into the directive. And we are also very pleased that the new directive, if the words do go through, it clearly states that midwives can independently and autonomously work with women through antenatal, intrapartum and postnatal period. And that should help midwives with their level of education and understanding shape maternity services that are sustaining the quality and the safety of the care for all the women in your countries. Thank you.